So my medical training's in cancer, leukemia, and so I am a physician, but right now my MD stands for mouse doctor. I spend, is what my family says, I spend time doing research. And so by disclosures, I have patents in autoimmune disease, cancer, and I'm a consultant for Cabaletta that you'll hear about later, and also with Capstan, which are relevant today. The name of CAR T cells, it goes back to the Greeks, and it was for that mythical three creature made out of the head of a lion, a body of a goat, and a tail of a serpent. And that's because a CAR T cell is a chimera. It's a hybrid of a B cell and a T cell in your immune system. So B cells normally make antibodies, and T cells normally, came into really evolution to kill viruses. So the two are really good partners, and a CAR T cell then combines the best of both. So how a CAR T cell works is here. There's on the top on the right is a T cell that has its T cell receptor, which is TCR. Those evolved to kill viruses. And then with gene transfer, we can put in a molecule called the CAR, the chimeric antigen receptor. And then now the cell has two jobs. It's a T cell that can kill a virus, but it also now can kill whatever you target with that antibody, which is, in this case, is CD19, which happens to be on leukemia cells and our B cells, and the B cells that cause autoimmunity. And what it does then is it selectively then kills that cell. So that's the principle of how they work. And the first idea to make a CAR T cell was back in the 1980s in two papers on the upper right, one from Japan and one from Israel. That one from Israel was, the senior author was Zelig Eshar, and on the right is a photo with me there at the Weizmann Institute in 2009. So he never treated cancer. He was just trying to ask, with basic research, can you make this chimera, put a B cell part of the antibody into a T cell? And he showed in Petri dishes that could happen. So Zelig called them T-bodies. At Penn, I'll tell you, we made the first CAR cells for cancer, and we called them rat cells, which was kind of a bad name. And then Michelle Sadelain and Rainier Brinchens at Memorial Sloan Kettering wrote a review, and they called them chimeric antigen receptors, or CARs, and that's how the name stuck. So the first protocol that I wrote, at the University of Pennsylvania is here, where this is for patients with leukemia. We made cells called RAT19, and that stood for redirected antigen receptor targeting the CD19 molecule, which is on leukemia and normal B cells. And so that's how the study design was. And actually, our first patient was treated in 2010. The photo on the right it was Bill Ludwig, who was a retired Marine, and he'd had many times refractory leukemia, but he had a response. And then he lived for 10 years with no leukemia, and he actually died of COVID in 2021. But we learned a lot from him. So going back, you heard about the Greeks. The Romans also thought about things. And they said, Cicero, that if you find how something's broken, you can learn how to put it back together again. Kind of like, I think about even as, working on auto mechanic like I like to do. And so I went to Penn in 1999, and Peter Knoll was there, who had discovered what's called the Philadelphia chromosome. That was the first genetic cause of cancer, and it was basically two chromosomes that come together and then make leukemia. And, so he discovered that in 1963, but it took until 2001 to get imatinib, which is the first treatment of that. So basically about 40 years. So, if you knew how something was broken, why did it take that long to fix it? And with CAR cells, as I mentioned, we first treated Bill Ludwig in 2010, and 7 years later, it was FDA approved. So we now have a whole hundreds and hundreds of new cell and gene therapies happening. And the good thing is that the cycle time of how long it will to get FDA approvals is going to be much shorter than that 40 years that we used to have. So how do we get to CAR T cells? I mentioned the top part. There's really a genealogy of 3 branches of science that had to happen. And number 1 was Zella Geshar on making, putting the antibody part into a T cell to make a hybrid or chimeric cell. Number 2 was you had to learn how to grow T cells, and that's where my lab came in. So if you have, a lot of you probably know that, blood transfusion, there are universal donors. I happen to be one. If you're O negative, you can give your blood cells to anyone else, so you transfuse them. But for T cells, you can't do that. Unless you have an identical twin, you cannot transfuse T cells from one person to another. So we had to learn how to grow T cells to make CAR T cells because, they come from the patient themselves. And then the third part, in the bottom of the genealogy was learning how to put genes into T cells. And that was done initially with viruses called gamma retroviruses out of mice. And then we used a modified form of the HIV virus that's been gutted out so that it doesn't cause disease, but it's really efficient at putting new genes into T cells, and then they stay there. So all that led to the FDA approval of CAR T cells in 2017. But this now shows where we are. I mentioned there's hundreds and hundreds. There's over 1,000 trials now with CAR T cells. And this radar plot there's 7 of them in the center that are FDA approved for blood cancers in the U.S. But as you go out towards the periphery, they are experimental therapies, phase 1, of which where we are now for autoimmune disease. And but there's all kinds of cells. There are cells derived from the patient themselves, autologous. That's most of those at 10 o'clock on that plot. But then at the top at midnight are cells derived from other people with genetic modifications. There's natural killer cells. All these things are being tried. So there's just lots of innovation, and it's a tsunami of new kinds of therapy for cancer and autoimmune disease. So, what CAR T cell therapy was, we did it really initially as just an academic experiment. Could we actually retarget cells and then give them to people? And then would they actually do the job we wanted to, which was kill a selected target? And there was no precedent for that in medicine where you would, make for each patient a specific new therapy. Which is called an N of 1. What all the things we've had in the pharmaceutical industry is they're made, at a big central manufacturing plant and then given to patients. So CAR T cells were really disruptive because it's like a bone marrow transplant. You start with number 1 up there, which is taking the cells out of the patient, unless you have an identical twin. And then you do the reprogramming of the cells to put the CAR molecule in, and that's steps 2, and 3. And then the cells get shipped back, and then they're infused back. It just takes 5 minutes into the patient. And so those are autologous, meaning the patient's own cells. They're trained to become then CAR T cells. Now, allogeneic just means they come from someone else. And there's a lot of ways to do that. One is using cord blood. So when babies are born, there are T cells in the umbilical cord that are normally just thrown away. And you can take those and make them, and if you use genetic modifications, you can use them, healthy adult donors, and then pluripotent stem cells. Now, in the beginning this morning, we heard of this remarkable paper last month, or 2 weeks ago in the New England Journal, where 12 patients with type 1 diabetes were treated with induced pluripotent stem cells, that's PSC, that were turned into islet cells that make insulin. Okay, and people are also doing the same thing to take these cells that you can grow in large vats and then turn them into T cells. And then you don't have to have the complex manufacturing process of going from the patient to a manufacturing and then shipping back. I'll mention a little bit at the end about so-called in vivo CAR cells, which is where you don't even do any manufacturing outside of the body. It's just you inject right into the patient, and then they're made in the body itself. So there's lots of things happening in this area. But at this point, the only FDA-approved ones are, using the patient's own cells. So we've had those since 2017. So there is the website, and I'm sure a lot of you looked at clinicaltrials.gov, and it shows all the registered trials around the world for different cell therapies and trials in general. And if you put in the search term chimeric antigen receptor, which I did in May 22nd of this year, it said there are more than 1,600 trials now with CAR T cells. And the heat map in red, shows that most of those are in the US and China. And so that's where most of the development's happening now. And over 100 of those trials now are for autoimmune disease, CAR cells. And you're going to hear a lot more about that here. So it's very exciting now that this is happening. The autoimmune is really kind of surfing behind the experience we have now over the last 20 years of CAR T cells for cancer. So this is where my journey, we worked for about 20 years. And then in 2010, Bill Ludwig was infused. We then, reported that in the New England Journal a year later. And it really triggered a lot of interest because, we had real evidence, the way from how Bill Ludwig responded that, in fact, the CAR T cells had worked. It didn't take, it was like we had a smoking gun. There was no doubt they had worked. And so at that time, there was no pharmaceutical industry to do CAR T cells. No one ever thought it could be a therapy that you could make available. And it was only done in academic centers. And then, Novartis got interested. They licensed the CAR cell made in my lab, and then now there's hundreds of biotech and pharma companies making CAR T cells. So that was one of these things where literally we had 3 patients reported, and then there was this tipping point where everyone said, "Oh yeah, it really does work," because up until then there had been a lot of disappointing results, and it had never worked. So, sometimes, you just need to see one, like I have a friend who said, dogs can't bark, but if you see one dog talking, then dogs can't talk. And we had a couple of patients, and that then made it where we now see there's a path forward to do it. I think we have that now in some autoimmune patients. That's really pretty exciting. So then in 2012, we treated Emily Whitehead, and you saw a little bit about, there's a full-length movie called Of Medicine and Miracles about her story. It's on Amazon Prime and iTunes. But it's a documentary made by LaRosse Kaufman, who had filmed her from when we treated her. So on the left is a second patient we ever treated with leukemia. He's now 78 years old. He came back this summer. This is about a photo about 6 weeks old. His name is Doug Olson, and where he's standing is where we actually made his cells. Now, we have shown that 15 years later, so he was infused 2010, he still has CAR T cells. So they can be a living drug that can persist more than a decade. And we can show that they still will fight tumors, and he doesn't have any cancer. So that's a principle, that they can be a so-called living drug. You can take your own cells out, modify them, and we think for autoimmune disease, that's going to be a powerful thing. Now, Emily Whitehead is shown on the right, where, after, she was treated when she was 7 years old, and you can see there it was 11 years after. And she's now a freshman, or now going to be a junior at the University of Pennsylvania. But it wasn't an easy story with Emily. So on the left is, we infused her in early April of 2012. And what that is a plot of cytokines, and you heard a lot from Dr. Mann about cytokines and the JAK stats that make them. So she has, and that's a log scale. So at baseline on day 0 there, then it shows cytokines like IL-2, IL-6, and interferons after we treated her CAR cell. And 3 days later, they were over 1,000 times elevated. And she had very severe cytokine release syndrome. We thought she was going to die, but she didn't. And this is what the scientific paper was about her. As I mentioned, we on the plot on the right, she had a baseline temperature of 37 degrees, which is 99, 98 Fahrenheit, and then it went up to 106 degrees. And it lasted for 3 days. That's her temperature curve there. And others are biochemical of showing organ damage, lactate LDH, lactate dehydrogenase. And we showed it wasn't an infection. That's what it usually is in cancer patients when they get high fever. Then we found, she had these really high levels of cytokines. And she had multi-organ failure. She was on a ventilator. And so we tried, once we found out it wasn't an infection, we tried steroids, very high dose methylprednisolone. Nothing happened. And then we tried blocking TNF with etanercept. Nothing happened. And then as a last ditch, tocilizumab. And that was luck. Because my family has had autoimmune disease. My great-grandmother had rheumatoid arthritis. My mother had lupus. And my daughter on the left there, Sarah, had juvenile rheumatoid arthritis diagnosed in 2001. And she's been on methotrexate and Plaquenil since then, since age 9. And so I then, as a father of someone like a lot of you, watched what's the new experimental things for autoimmune disease. And in 2009, I was the president of the Clinical Immunology Society, which is a group that it has immunologists that studies cancer, autoimmune disease, infections. And so it brings them all together. And so from that, as a president, every year you get to give a presidential award. And in 2010, I gave it to Tada Kishimoto, who had invented tocilizumab. So that's a drug that got approved in 2012 for juvenile rheumatoid arthritis. So I knew about it as a leading edge therapy for my daughter. And then we had in April, Emily Whitehead had 1,000 times higher level of interleukin-6, which is what tocilizumab blocks. So, when she was in the ICU, I told the clinicians, the pediatric cancer docs, why don't you try it? And they did, and it worked. So that was, serendipity. And it saved her life. So tocilizumab is approved, been tried for JM. It's been tried, and it works very well for JRA. It blocks, the JAK stat activation that you heard about that raises IL-6. Now, IL-6 is what causes fever. So if that and a cytokine called IL-1. And now it's clinically given for many diseases like JRA, rheumatoid arthritis, Castleman's disease. And now then, the FDA, based on the response that Emily had, it's been co-labeled for all the CAR T cells. So if you get any of the commercially approved CAR T cells, if you get cytokine release syndrome, you get this as a treatment, and it's very effective. So Emily lived through that, and you can see this here. She now, as I mentioned, is majoring in English at the University of Pennsylvania. And in March, they had a Stand Up for Science rally in the mall in Washington, D.C. And she was the one chosen to speak there by the director of the National Institute of Health, and she did, and what she said was, without funding research, I wouldn't be here. And that night on the upper left, she was on Jake Tapper and CNN, and so it gave a lot of public, education about why we need research, and I think autoimmune disease is going to benefit a lot from cancer research, and so on. We need to have research now to make cures. So, where are we? There are, as I mentioned, 7 FDA-approved CARs, and cell therapies for cancer. What Emily had, and the most common pediatric malignancy is leukemia, acute lymphoblastic leukemia, ALL. And if you've relapsed, it means you're dead, basically. And now with CAR T cells, there's been an 80 to 90% complete remission rate. And so it's really transformed the treatment of that. And the next one down is non-Hodgkin's lymphoma, which is a very, it's a common, there's 60,000 cases a year in the U.S. in adults. It's not a childhood disease. And there's been a 50 to 70% complete remission rate now with CAR T cells for that. The first patients we treated, I mentioned Bill Ludwig and Doug Olson, had relapsed refractory CLL. Same thing, it's incurable. And there's been a 50 to 70% cure rate. And just last year, Bristol Myers got FDA approval for that with a CAR T cell. The most common blood cancer in adults is myeloma. And it's, thought to be incurable. There's a different CAR. Instead of targeting the molecule CD19, the molecule that's targeted is called BCMA, so B-cell maturation antibody. So the CAR is the same, really. I mean, it's a patient's own T cells, but now the antibody that's put in, instead of binding to the CD19 molecule, binds to the molecule on the myeloma cells called BCMA. So this really shows, and it works great. There's a very high, it says 80 to 100% overall response rate. And the reason I'm mentioning this is, it shows that it's not just a one-trick pony. You can make CAR T cells targeting almost anything you want, depending on the antibody put on. But there's also a lot of autoimmune disease caused by the cells that express BCMA. Those cells are plasma cells. They're not B cells. So there are trials now using anti-BCMA CAR cells for autoimmune disease, and particularly some of the CNS ones. And then there are, trials with CD19. And if you look on clinicaltrials.gov now, there are even trials in China with combinations targeting BCMA and CD19. So then you would target the B cells and the plasma cells, and both of them can make antibodies. Now, we have one very exciting trial funded by the National Institute of Health at Penn. If you have kidney failure or a liver failure or a heart transplant, you need a heart transplant, that can save your life. But about 2/3 of people never get the organ transplant. And that's because they have antibodies that prevent them from getting a donor, whether it's cadaveric or because of, they have antibodies either made by plasma cells or B cells. So we now have one patient now from this NIH-funded trial where the patient was on hemodialysis, could not get a transplant. He was one of the 2/3 of patients who never do. And we were able to treat with a combination of CAR cells against CD19 and BCMA. And then those antibodies went away, and then we were able to give him a kidney transplant. And it worked. So there's going to be a lot of benefit of CAR cells for cancer, autoimmune disease, and I think organ transplantation. Because right now there's these huge lists of patients who can't get transplants for those reasons. So now these are the 7 FDA-approved indications. And They're made by, the large pharmas in the U.S., from Bristol Myers, Novartis, and now one actually from the UK, Obicel. They target at this point CD19 or BCMA, and you're going to see trials for autoimmune disease for both of those. And then we're going to see in solid tumors, the more common breast cancer, lung cancer, and so on, many other kinds of targets. And there's hundreds of trials for those. But right now, they're not yet FDA approved. They're all experimental. So this sums up, some of the status. I mean, we have commercially approved CARs for cancer now, targeting CD19 and BCMA. And there have been more than 50,000 patients treated. We have, they first became FDA approved in 2017. So we have like an 8-year time to look back at safety at this point. And they've been, they've turned out to be very safe, much safer than chemotherapy. They do cause, long-term in some patients B-cell depletion, which means in some cases you can have more susceptibility to infections. And so that's treated with one of the treatments for JM, which is intravenous gamma globulin, IVIG, if the patients need it. The allogeneic CAR cells at this point are all experimental. There's also many trials now with so-called natural killer cells, NK CAR cells. And I think those are going to all get FDA approved over time. There's many trials with combinations of CAR trials. The main issue really is how to make autologous cells more convenient to give. Shorter manufacturing, not have the complex manufacturing and so on that we have, and the cost. Right now, they're expensive. They're much cheaper than treating lifelong with chemotherapy, but right now they are expensive, and there's a lot of work to bring down the cost, and that's something that's happening. So there's a lot of new kinds of CAR T cells that are genetically have other switches in them and so on to make them either more potent or safer, so that the physician can turn them on or off. Right now, the way the CAR cells are, they're on. Once we give them, they stay on, and they continue to target whatever the molecule, like CD19 or BCMA in this case. So there's a lot of new kinds happening, and those are all experimental at various centers around the world. And there's also these kinds of CAR cells where they're made in the body, which we call in vivo CAR. And so we have trials at Penn called trucks, dual CARs, and armored CARs. All these are for solid cancers. For B cells, we don't really need them because they work really well the way we have it. Now, we have worked at Penn on these so-called in vivo CAR cells, and this is an example of a paper we had in Science a couple of years ago where we injected particles made by Drew Weissman, who got the Nobel Prize for the COVID vaccine using RNA. And what we're doing here is injecting RNA to make short-term CAR cells. Right, in this case, it was in mice. And we showed that we could, where if a mouse had a myocardial infarction, then it gets a scar in the heart, which is what happens with repair in the heart. So then the heart doesn't work as well. We showed that we could fix that with CARs in this patient with, cells made right in the mouse's body. And just last week, we had a paper in Science where we did this in monkeys, and we were able to inject right into the vein intravenously into monkeys these short-term CAR cells. So they only last about a week. So it's not like the ones where we make them out of the body and they can last 10 years if we want. So these lasted for a week in the monkeys. But what the bottom shows on the left is a control spleen from a monkey, and the stain and those are B cells. There's a lot of them. And what we showed was we could as we gave increasing doses of these RNA called targeted lipid nanoparticles, we could get rid of the monkey's B cells in there. So eventually, it may be possible to make these right in the patient, without having to do all the complex manufacturing. But the first FDA-approved ones are for sure going to be autologous CAR cells because we have a very long safety record with them. So I think we're going to have, as I mentioned, autologous CAR cells where it's the complex manufacturing, but we know how they work, and they're infused into the patient after the manufacturing. The initial manufacturing we did with Novartis was 12 to 14 days, and we've just done a trial at Penn where now the manufacturing in the lab is 3 days, so a lot more convenient for the patient and the docs. And then there's going to be these in vivo kinds of therapies like the targeted lipid nanoparticles where it's just RNA that's shielded is injected right into the body, and then you get short-term CAR cells. That may have a real advantage of not having to give chemotherapy for lymphodepletion because we didn't do that in the monkeys, but we're going to find out about that. That requires, so they only last days, whereas the autologous ones on the top can last years. So we're at this real, I think, disruptive tipping point now where CAR cells, they've been established in oncology, are going to go into fields where, for instance, organ transplant, as I mentioned, we have really exciting data from our NIH trial on that, and autoimmunity, and we're hoping downstream to do cardiac disease. So what about autoimmunity? I mean, we've been interested in that, and I have been interested just because of my family history. Dan Baker is a graduate student in my lab, and he wrote this review in Nature about the increasing use of CAR cells, and this just shows a plot of trials in, most of these are adults, but from lupus and myasthenia gravis and so on. It's really, as I mentioned now, you'll find more than 100 trials on clinicaltrials.gov. So it's all experimental now, but it's really exciting. And then the whole world really changed from this trials done in Erlangen in Germany, led by Georg Sett and Andreas Mackensen and Fabian Müller. So they, in a series of trials in Germany, in single patients treated with a CAR almost identical to the one we use in leukemia, they treated 15 patients that had adults, refractory lupus, myositis, and scleroderma, and they had a 100% response rate. It was really, really amazing. And they showed on the right, that's a plot of this, one of the patients. The first patient was actually a Vietnamese woman living in Germany, and she had lupus treated with everything in the kitchen sink you can see, from rituximab to tacrolimus, cyclophosphamide, et cetera, and of course steroids. And then she got a single infusion of the CAR cells, and then those pathogenic antibodies against double-stranded DNA went away, and she's now more than 3 years out on no further treatment. So that's the first patient treated. She's really the first Emily Whitehead-like patient in autoimmune disease. Now, when I went to medical school, and steroids were discovered in the late 50s and 60s, we had them, and we used it to treat inflammatory diseases. And so all the textbooks when I went to medical school said that if you wanted to treat autoimmune disease, you either had to do immunosuppression, which has all the complications that a lot of you have seen, or another is fix a system and try to reinduce immune tolerance. And that's using cells that are so-called regulatory T cells. Those are the ones that we normally have that balance between turning your immune system on and off. What the German studies now have shown is something completely different that none of us really thought, and it's called immune reset. And that basically means like if it's turn the computer on and reboot it. And what the CAR T cells do is they transiently get rid of all the B cells making these bad antibodies. And we had all thought that the system, when it came back to, after it rebooted, that it would come back and just do what it had already done. And you would have a mixture of antibodies, but you would also have the ones that cause the bad things, like double-stranded DNA, and you would get right away your autoimmune disease back. That's what we all thought, but they did the trial and found out we were wrong. It was an amazing thing. All the mouse studies were wrong. We had all been working for 50 years trying to do immune suppression or immune tolerance, and I did my initial lab work on immune tolerance, and it's turned out an immune reboot may be a really promising way. And so that's why I think we're all here. It's I think a new concept now that was, we can thank the Germans for doing this study. I tried to do this in the U.S. and our FDA was not receptive to it. They thought it was too dangerous. But the Germans were able to do it. They have a more flexible system. And now we have many trials here in the U.S., fortunately. So there are a lot of autoimmune diseases. Cure-JM is a very rare one, but it's a really bad one if you have it. 1 out of 10 people have autoimmune disease. I have psoriasis. My daughter has arthritis. My grandchildren have arthritis. It runs in families. 50 million people have maybe some form of it. And so it has actually a bigger impact economically than does cancer. Okay, because cancer either, you get treated and you get better or you die. With autoimmune disease, it can be like my daughter who was diagnosed at age 9 and she's still on autoimmune disease daily, the therapies at age 31. So the costs add up, much more to our society than they do to cancer. And the side effects then accumulate, and that's why we need cures. So we have this huge economic burden estimated over $100 billion, whereas, for non-Hodgkin's lymphoma, NHL, there's, we have, 60 to 80,000 cases a year compared to the 800,000 Americans with lupus and so on. So anyway, it's a huge unmet medical need, and your group here has a huge, reason really why we need to have this. So they could be transformative for B-cell driven autoimmune disease, the CARs that we have. We know that there are these cells that live in the tissues. They can be in joints, they could be in muscles, or they could be in the brain in multiple sclerosis that, target your own cell and systems. And if we had a way that would get into those tissues and kill those B cells making those antibodies, we might be able to get what's called B-cell aplasia and then an eradication of the disease. And so this would lead to, the immune reset. It wouldn't be just, every day taking a medicine to suppress the immune system, but it would just be rebooting. And then you wouldn't have to take long-term immunosuppressants. And it could be curative. Now, we now know it can be curative in cancer. I've showed you our initial patients where we have 10 years or more of follow-up. We don't know if anyone's cured yet with autoimmune disease. As I mentioned, that first lupus patient in Germany now is 3 years out. There's going to be some relapses. We don't know how often it will have to be retreated and so on. But right now, in the selected patients we have that have been reported, really exciting results. So this is from a review then that George Sett and I wrote about autoimmune B cells on the graph on the top, and what CAR T cells could do, which is you stop the immunosuppressive therapy and give CAR T cells. They then proliferate in the body for a while. They eradicate the B cells that are making antibodies, including the ones that are destroying tissue, causing myositis. And then, this immune reset happens, shown here about day 100 on the plot. Normal B cells come back, and you have then a normal immune system where you can get rid of viruses and stuff, but you're not attacking your own body. So this is, the challenges are shown at the bottom. The main issue is, do we have to give lymphodepletion? Right now, we give 3 days of chemotherapy before the CAR T cells. It's one of those drugs that we give is already given for autoimmune disease. That's Cytoxan. But the other is fludarabine, which helps the CAR T cells when you put them in. And so what, on the right, the long-term challenge is how long is it going to last? And will there be any long-term side effects? And the only way we're going to know on that is doing clinical trials. So there's a lot of rationale to do this. On the top are various diseases of which, you can see in adults and pediatrics, various issues with them and the rationale why they might be, there's in each of these some reason to think that B cells have a role in causing disease. There's a lot of unmet medical need because there aren't curative therapies. For a long time, people have tried autologous bone marrow transplants for really bad autoimmune disease. And a randomized trial actually has shown that it works in multiple sclerosis, which can be horrible. But the problem is autologous, transplants are very high-dose chemotherapy, and very few people are well enough to get it, and it's never really spread. So, but there has been, through autologous transplants, the idea that immune reset could work. But it's just not been able to go out into and be useful really in general medicine. So there's a lot of reasons to suspect that these, diseases that rheumatologists see. And my second son, by the way, is a rheumatologist, an adult rheumatologist. And that's because he watched his younger daughter, his sister, grow up with arthritis and has seen it. So this is that really practice-changing paper from the German group that came out in Nature Medicine. They're reporting their first 5 patients, and initially it was lupus, but then they did myositis and scleroderma. They all had transient B cell depletion. That's what the graph on the lower right shows, that where they had disease activity was a lot, and then it went away. Their double-stranded antibodies on the upper right went away to DNA, and their B cells transiently went away in panel C and then came back. And they had all 5 patients have complete remissions within 3 months, in spite of having all immunosuppressive drugs stopped. And this just shows more about that, the disease activity index going down to baseline on the left. You can see the photos of cutaneous lupus and arthritis getting better. And this is from Fabian Müller, who just recently visited Penn to tell us about his updated results. And the good thing is they now have about 50 patients treated there in Germany on their academic trials, and they're continuing to see very high rates of remission. So they have focused initially in Germany on severe lupus, adult inflammatory myositis, and systemic sclerosis, and they had 15 patients. And all the patients now are off all immunosuppression. So it works. Now these are selected patients that they see. They have a lot of experience there on picking out who you want to treat, and that's something medicine has to learn. Because if patients are immunosuppressed for a long time, they may have more susceptible to getting infections, and then the CAR T cells could make that worse, and so on. So, all patients can't necessarily get this, and we need to learn exactly how to mimic what they've done in Germany, where they've had a really high level of response rate and low complications. So there are lots of things. One is, we're early into this, and one main risk that they may not work in randomized trials and controlled trials. We'll have to see. So we need clinical data to really show, and that's now happening in the hundreds of trials around the world. Another issue is, I mentioned that we give 3 days of chemotherapy before the CAR cells, and then and that makes, we know from our leukemia data, they work better if we give that. There are new advanced kinds of CAR cells that may not require chemotherapy, and those are going to be tested. So we hope to be able to get rid of that eventually, but right now it's a short-term effect that's been shown to be safe in many settings. There's the issue I mentioned that it costs money to make these because they're made on a one-by-one basis, but it's actually cheaper than it is treating with a lifetime of biologics, which can be easily $10,000 a month or more. I'm sure all of you have seen that if you get your insurance bills. So, the costs are going to go down as the manufacturing gets automated. And then there are other approaches that, in the next 10 years will make it come down dramatically more. We don't know if there's going to be long-term immunosuppression. So far, that's not been an issue in the patients followed up in Germany. And, do the patients need to be vaccinated more? And all that is going to be tested. And if they've had a BCMA CAR treatment, then that takes away your memory plasma cells. That means you need to have revaccination. Right now with CD19 treated CARs in adults, the patients don't need to be revaccinated. There's been concerns about rare, could the CAR T cells act like a Frankenstein cell, and turn malignant itself. That's been very rare. So we now have, over 50,000 patients to know that. It was initially a theoretic risk. If we would modify a cell with a virus, would that turn it into some kind of, rogue cell? So the data is it's rare. So what about bispecific antibodies? There's also a lot of trials with those. And the answer is we don't know yet. They're going to work sometimes. In Germany, at least in rheumatoid arthritis, they gave transient benefits, but then it came back. So I think we're going to see, both lots of trials, both with, the cell-based therapies and then give the recombinant bispecific antibody approaches. And I think it's going to work in with what we heard a lot about, the JAK inhibitors. There's going to be lots of combinations, and we just need to learn how to do that. So it's a lot of very exciting science right now that requires clinical trials so that we can get to an answer, and not have guessing and so on. So that's a good thing right now, is that this is happening in a very active way. And, we're going to then come to a convergence of what works best for when to use it and for whom and so on. All that's going to take some time. But I think the good optimistic thing is it looks promising. So there's, a lot of initial exciting data. We know initially that these are selected patients, from, small clinical trials. So far, the safety profile has been really good, especially when you compare it to the risk of long-term therapy. There's not enough patients reported yet, and I think this could have, in the end, a huge impact on patients with, diseases right now that are refractory to therapy. So, summary, there's a lot of active research right now, lots of exciting in adults, particularly with refractory lupus, sclerosis, and myositis. And we need, these larger controlled trials. There'll be advances in CAR engineering in many ways and addressing the cost barriers. So I'd like to thank a lot of people at the University of Pennsylvania, Children's Hospital, David Porter and Peter Merkel, who are at our group that are doing and leading the autoimmune trials. And thank you for your attention.